Welcome to this satellite symposia organized by EAO in collaboration with Neoss on 3D bone augmentation using non-resorbable membranes. I am Christer Dahlin. I'm a professor in Guided Tissue Regeneration at the University of Gothenburg. We are today at the Department of Biomaterials, a department with a long history in osseointegration, but also having a strong focus in tissue regeneration. We have a close collaboration with Neoss, where we are a part of their comprehensive development program of the NeoGen non-resorbable membrane. This unique membrane, with the two sides individually designed to optimize the integration with bone as well as the soft tissue, is supported with more than 5 years of clinical documentation. I would like to start this symposium by sharing with you some of the biological rationale which is the background to this new generation of NeoGen membranes. The principle of guided bone regeneration was initially explored using an expanded PTFE membrane. This type of material had excellent healing capacities and an excellent regenerative outcome. However, there were some drawbacks with this type of material, which initially also comprised of a more homogeneous type of ePTFE material. Recent findings has demonstrated for us that the membranes does not only act as a passive barrier during the healing phase, but it also takes a more active part during the healing process. We also have to take into account that we have more than one tissue types that are involved in the wound healing process. We have the bone and we have the overlying soft tissue, and these are tissue types which has very different needs when it comes to the healing phase. And the idea with this new generation of membrane has been to optimize the membrane for the respective tissue types. If we take a closer look on the NeoGen membrane, you can see that it comprises of two different types of configurations, one facing the bone and one facing the overlying tissue. It is expanded in its character, but what is also novel compared to the first generation is that although this is an expanded kind of network type of structure, this type of membranes are absolutely 100% occlusive for instance, for bacterial ingrowth. The structure of the membrane with its expanded character is of great importance for the initial cell attachment. This is illustrated here by these two SEM pictures that you see on these slides. To the upper left you see fibroblasts that are occupying and migrating on an expanded PTFE surface in a typical spider shape manner. A fibroblast seated on a dense PTFE surface, as illustrated on the lower left, has initially more difficulties to achieve this type of attachment, and we believe that these differences in structure is of great importance for the initial clinical outcome of the healing process, which is essential for guided bone regeneration. Now I would like to introduce our first speaker, which is Professor Massimo Simion, who is a professor in periodontology and implant therapy at the University of Milan. Massimo is considered one of the pioneers in developing the clinical concept of guided bone regeneration, and we have known each other and collaborated on this topic for almost 30 years. So Massimo, please.
Thank you, Christer, for the nice presentation. It's a pleasure for me to be here and share with all of you my presentation for the EAO Satellite Symposium. We are going to speak about vertical ridge augmentation in cases of aesthetic areas. First of all, the first publication that we did about vertical ridge augmentation with the non-resorbable titanium reinforced membrane was in 1994, And in this publication, we just did a kind of a proof of principles to demonstrate that it is possible to augment the bone vertically with this kind of GBR technique. Then we did a second publication together with Sasha Jovanovic in 1998. And in this publication, we used machine surface implant together with a GBR technique with the autogenous bone chips and the titanium reinforced membrane. As you can see here, the implant are sticking out from the bone for about 6 to 8 millimeters. The membrane is placed and closed with tacks, and we have a primary closure. After a period of about 6 to 7 months, you can see the membrane has been reopened, showing the underlying regenerated bone and the implants that are completely surrounded by newly formed bone. And this is the final result. But let's go to the topic of today, the use of GBR for aesthetic areas. This is a case in which a young guy was 30 years old, and he has been treated with an implant that had severe perimplantitis. As you can see, there is a pus formation, pus secretions from the sulcus, and you can see also that there is a big defect in the CBCT. First of all, we have removed the implant with an instrument, a reverse torque instrument, and you can see the crown is completely filled with this kind of material. Is probably calculus or cementum and residual of biomaterials. And in the CBCT, you can see that there is a huge defect, and there are also some remnants of the hydroxylapatite that was implanted before. And I'm showing now a short video to demonstrate exactly what we do during the surgery. We make a vertical releasing incision, one tooth further, then we turn the blade and we go intracircularly, and then we cut all the fibers of the periodontium all around the tooth until the palatal aspect. And we usually in the palatal aspect go one tooth further to have a larger, wider flap. Then we make a crestal incision more to the buccal aspect, because we want to have a short buccal flap and the long palatal one, because at the end of the surgery we will reposition coronally only the buccal flap, so it's much better to have a short buccal flap. Then I'm making the vertical releasing incision on the contralateral aspect. We have to center the papilla, and just at the end we turn the blade and we go intracircularly, just to make a so-called golf club shaped incision. Then with the sharp elevator, I'm starting to elevate the flap full thickness, starting from the papillas in the central incisor, and then going very close to the bone to elevate completely the periosteum. Then we go to the contralateral tooth, elevating the papillas first, and then continuously elevating in the apical direction. Once we get in the area of the defect, we have to be very careful not to damage the flap. And finally, we can find the bone apically to the defect. Then we have to continue to elevate the flap full thickness as much as possible to the nasal spine. Now I am elevating the palatal flap very carefully, and I'm removing all the soft tissue from the nasopalatal canal and from the defect. We don't want to leave any soft tissue left in the site. And also we wanted to remove completely the remnants of the hydroxylapatite, because could be infected. Then this is the time in which I'm placing a tenting screw more in the palatal aspect to support the membrane and to avoid the collapse of the membrane into the defect. We have to choose a height, a length of the screw in such a way that the head of the screw is at the level of the cementoenamal junction of the adjacent teeth, as you can see here with the probe. And then I'm placing a second tenting screw more to the buccal to be sure that the membrane is very stable and at the right level. Now I'm cutting a NeoGen membrane, which is a EPTFE membrane with a titanium reinforcement, in such a way that it is not going to touch the adjacent teeth. It's very important to maintain a distance of about 1 millimeter from the membrane margin and the adjacent teeth to avoid infection through the sulcus. The membrane is fixed with 2 screws in the palatal aspect, very slowly, very carefully. Always 2 screws because we don't want the membrane to be able to rotate and to move during the suture or at the end of the surgery. Once the membrane has been placed palatally, we place the graft. This is 90% of autogenous bone chips collected from the retromolar area in the mandible and about 10% of deproteinized bovine bone. We have to fill first the palatal corner, and then we add material progressively to the buccal aspect. And we have to put more material that is needed because we have to compensate the possible resorption after membrane removal. Then the membrane is fixed with some tension to have a perfectly stable membrane. We don't want to have the membrane moving or vibrating. The more stable is the membrane, the better is the bone regeneration. This is another very important step of the surgery, which is the releasing incision at the base of the flap in the periosteum. This releasing incision is done to be able to reposition coronally the flap and have a tension-free suture, which is important, essential for a good suture and to avoid the membrane exposures. Now we check, you see that the flap is very loose, it's reaching the incisal edge of the adjacent teeth, so we are now ready to place the sutures. We have also to make a little bit of stretching of the flap to be sure that it is really loose and elastic. The first suture is an horizontal mattress suture with the EPTFE, about 50 or 40, and we place this first because you want to have a kind of extraflexion of the 2 flaps that have to face each other with a deeper portion, the connectival portion, in such a way that they can heal properly. We don't want to have an overimposition, sovrapposition of the 2 flaps, because otherwise the epithelial portion will not heal toward the connectival one. At the end of the horizontal mattress, 3 in this case, we use Prolene suture 60 with just a simple interruptus stitches, and we place as many as possible to have a perfect adaptation of the 2 flaps to reduce the scars, which are very anesthetical, and to reduce the risk of penetration of bacteria, epithelium inside in the wound. And this is the final suture. The healing after about 7-8 months, depending on the size of the defect. You can see that the mucosa is very healthy, and we have augmented the volume of all the area. And in the CBCT, you can see that we have corrected the amount of bone, and we have a kind of a normal crest, normal according to the vertical dimension and also the horizontal dimension. After 7 to 8 months, we reopen the flap and we remove the NeoGen membrane. We remove the tags first, and then we elevate the membrane like a flap. And in these cases, all the time I place hybrid implants. And it's very important to have at least 3 millimeters of thickness of bone buccally to the implants to prevent kind of resorption. Then here I am augmenting the thickness of the flap with collagen matrix from porcine to have also an augmentation of the soft tissues, which is very important for the final aesthetical result. And you can see here in this small picture that we have enough tissue, soft and hard tissue buccally to have then a final good shaped crown. And this is the final crown after 6 months of provisional restoration, and you can see that we have nice papillas, nice volume, and also we have a control in which you can see that the bone is a perfect level and no sign of inflammation or resorption. And with this, I thank you very much for your kind attention, and I give back the microphone to Christer. Thank you very much again.
Thank you, Massimo, for this great presentation. Now I would like to introduce our next speaker, which is Dr. David González. David is a specialist in periodontology and implant therapy, and he's a very innovative surgeon and are currently running a private practice in Murcia, Spain. David, please.
Thank you, Christer, for the nice presentation. My name is David González. It's a pleasure for me to be here with Christer and Massimo, sharing with you our experiences. I will present this case. This is a 3D GBR case that I did using autogenous bone, 100%, and a NeoGen membrane. This patient had 2 implants which suffered severe periimplantitis, and they were removed. As a result of the periimplantitis, the patient had an oral sinus communication. We can see that we have a marsupial pocket where there was the fistula path, and we also have a lack of keratinized tissue. We can also see that we have a lack of papilla in the central incisor, and that we have a soft tissue deficit, a very severe soft tissue deficit. So we can see the palatal mucosa from the buccal aspect. This is in an occlusal view. We can see the horizontal atrophy. And this is the CBCT, where we can see that we don't have buccal bone wall, no palatal bone wall. So we have a very large defect. And we also have a communication, a bone communication between the sinus and the defect. So the fistula healed for second intention, and first thing we did was making a full thickness flap, raising a full thickness flap, taking care not to communicate the flap with the marsupial pocket. And after raising the flap, we can see a 25 millimeters vertical defect. And first thing we do was placing a NeoGen non-resorbable membrane. We fixed the membrane to the palatal flap by mattress sutures. And then we go to the chin and harvested some bone cylinders. After crushing the bone, we packed the bone inside the vertical defect. It's 100% autogenous bone. And then we placed another membrane in the buccal aspect, fixing it with tacks, and we sutured both membranes using resorbable 5-0 sutures because the defect was too huge. This process is no longer necessary because now we have a huge XXX large NeoGen membrane, and after releasing incisions in the periosteum, here we can see the matrix sutures in the palatal flap, we managed to obtain tension-free primary closure using matrix sutures to over-approach the flaps, and then using 6-0 monofilament the final sutures of the supracrestal area. This is the aspect of the suture where you can see that every papilla is in the original position. 2 weeks later, we removed the sutures, and 1 year later, we're going to do the re-entry. And the question is, why do we wait so long? Why do we wait 1 year? It's because we want to obtain completely healthy, bleeding, mature bone. We want mineralized bone so we can prevent any bone resorption. So, in our opinion, if we let it heal for a long healing period, 1 year, there will be no bone resorption. That's what I have seen in my experience. So 1 year later, we're gonna do the re-entry, and to plan the implant placement, we use the digital scanner. So we can copy the contralateral canine and the lateral incisor, and we can place the implant in the canine area. The implant will be one only implant in the canine, and the lateral will be a cantilever. Here we can see in a sagittal section of the CBCT how the implant is totally surrounded by bone and is located 4 millimeters away from the zenith of the crown. So we do the re-entry, we raise a flap, and when we raise the flap, we see the membranes, we remove the membrane, and we see the ridge totally regenerated by new bone. So now at this moment, we placed our computerized surgical guide, and we drill through the guide, and we can see the bone between the threads of the drill. And we place one only Neoss 4.5 15 millimeters long implant. The implant, as I told you, was at the K9 position, and then we took a soft tissue graft of the whole tuberosity. We removed the epithelium, and we can see here a closer view of the bone surrounding the implant. You can see the cortical aspect of the bone, and then we place the soft tissue graft totally fibrous. We fixed it like a saddle using sutures, and we cover the implant and the soft tissue graft totally. We leave it submerged. 2 months later, when we assumed that the soft tissue graft was integrated, we're gonna reposition the mucogingival line. So we do a split thickness flap to remove the elastic fibers, and we sutured the graft, the flap to the apical area, and then we obtain a soft tissue graft, a connective tissue graft from the other side of the palate, and we fix the graft using mattress sutures. This is the aspect of the ridge after placing the graft, and 1 month later, 3 months after placing the implant, 1 month later after reposition of the mucogingival line, we do the re-entry, we expose the implant, and we place a temporary restoration, and we can see the aspect of the temporary restoration and the final restoration. This is the aspect of the final restoration 1 year after placing. We can see that the bone is totally healed, and the mimetic aspect of the soft tissue, the papilla in the distal aspect of the central incisor, the panoramic X-ray showing the optimal bone level, and remember the starting point. When we have a marsupial pocket, we had no papilla at the distal aspect of the central incisor, no good keratinized tissue, the before and the after. Complete bone regeneration after 1 year healing using only autogenous bone and NeoGen membranes. This is a video that the patient allowed me to take, where we can see the nice aspect of the restoration and how we could copy the contralateral teeth. This is the final view. We can see the excellent status of the bone, of the regenerated bone, and how the Neoss implant is totally surrounded by mature and nice bone, and the aspect of the restorations. So it's been my pleasure to share this case and this experience with you. I hope it can be useful, and thank you, Christer and Massimo and the Neoss company for allowing me to be here. Goodbye.
Thank you, David, and once again thank you, Massimo, for 2 fantastic presentations. You have really showed us how you can push the boundaries and the possibilities of guided bone regeneration for the future. Thank you so much. And with those final remarks, I would also like to take the opportunity and thank you all for listening, and I wish you a good evening.